digressions is Medicaid and healthcare coverage at the bottom end of the spectrum. I do want to say that I'm really thankful to have a chance to speak to entering medical students. It always feels very momentous to me to be able to be here, and so it's great to see all of you. The objectives here are presented in part because they do guide what's in the slides, and the objectives also guide what is in the 4 or 5 test questions I drafted for the test, which are really tied to these. So we want to help you be able to describe in broad terms the major and smaller sources of insurance coverage, to characterize trends in coverage, to describe major ways in which lacking insurance affects access to care, describe who's covered by Medicaid and how that differs between states, particularly with regard to how different states responded to the Affordable Care Act or Obamacare, although there's a whole talk just on that, right? Yeah. And then to describe a possible argument for and against the notion that insurance improves health. First question is really to engage you in a little bit of thinking. When people say the words access to care, I wonder if I should have taken those little bullets off below it, but when someone says, I want to make sure people have access to care, those words, I just want you to realize those words connote a lot of different things. In politics, they usually connote the first thing, which isn't unreasonable since it matters, which is to be able to pay. But in the world and in healthcare scholarship, saying someone has access to care isn't just whether there's a payment source. There are these other things, that there's a place you could go where you could get the care. You can imagine a country which might not have, or a county in Alabama that might not have adequate primary care doctors, or adequate, even a hospital. So if there's no place to go, access becomes a problem. That there would be the ability to have a relationship with a caregiver who actually will receive you and make you feel like you are welcome there. That comes up a little bit in the disparities discussion that we're going to do in an hour. It could include other features, but I just sort of wanted you to realize access is more than what I'm going to be focusing on during this talk, which is more on the payment side. Another way to sort of reiterate the same principle, I assure you I'm not going to test you on this in the questions, but you know, accessible care at a broader, if you're thinking about it at a systems level, it includes who needs to receive care, what populations need it, are there clinics and hospitals, is there a payment mechanism? That's the green thing. I made it a different color because that's the focus of today's talk. And then do the services that are received produce the outcomes that people need? And even though usually that last box is tied to quality of care, the two are often related. So if you go to a doctor's office and you feel like you're treated with prejudice, you may not return. The outcome isn't a good return. If you feel that, and then it's not really access at some level, even though we might say, well, it's really a quality problem, but it becomes non-access. Of course, here we're going to be talking about payment for individual source services, and we're going to set aside some of these other things: infrastructure, human power, quality, values. Couple numbers. Different numbers come from different national surveys, of which there are a few, but an estimate of the total number of persons in the U.S. uninsured is provided, 29.3 million people. This estimate is 9.1%. I'm using what's called the National Health Interview Survey, which is a representative survey done by a government office. It's not the only sources you'll see. Being uninsured is more common for adults between 18 and 64. It's less common for kids and less common for people over 65. Anyone want to venture a guess as to why it's less common to be uninsured if you're a kid? CHIP, yeah, CHIP is the main reason. I would say Medicaid as well. Medicaid plus CHIP together grab up a lot of those. This again is the National Health Interview Survey. You'll see a slight difference on the next survey, but I think I'd put it in 3 age groups. And the dark blue line is the rate of being uninsured in adults aged 18 to 64. It takes a dip from 2010 to 2015, which really represents the period of the major programs under the Affordable Care Act, and then it stays constant in this particular survey till through 2017. And then you see, depending if you combine everybody, if you look at under 18, it's the same kind of trend. I think we just talked about why it's low for people under 18. Another way of looking at the stats would be from polls. Gallup is an organization that does national polls of political preference, of anything basically. And then those nationally representative polls, they come up with a hint that the percentage of Americans uninsured increased from 10.9 to 12.2%. So in any kind of test question, just to reassure you, the only wrong answer is to say that the percentage who are uninsured is still dropping since 2015. It's either gone up a little bit or it's stayed constant, depending which poll you use. Who's uninsured? I wonder if this is a little too small to see, but there are a couple points I drew out of this Kaiser Health Systems. It's the Family Foundation slide. It's nationally representative data. It's a few years old. Most families where people are uninsured do have a worker. They're not predominantly non-working families. Most families that are uninsured are above the poverty level. And so it's only about a quarter, the lower right pie slice, the upper right pie slice, dark blue, which has less than 100% of federal poverty level. Uninsurance is part of life for, every racial, ethnic group. It's a diverse lot in more ways than sometimes we realize. What's covering people? Now, this kind of is interesting because the maker of this graph tried to use color coding to show not just the major categories, but all the minor categories. And of course, it's not my goal to torture you with memorizing minor categories, but even on Affordable Care Act exchange coverage, which he's doing in blue here, and private purchases off the exchanges, he's kind of slicing and dicing very small groups, miscellaneous small groups. It kind of is a fun graph to study in depth. Small employers, public employers, large employers. Medicare, well, there's different kinds of Medicare programs. Probably the main thing to see is, well, there's this big swath of green, that's employers. And then there's this pretty big swath of red, Medicaid. And then there's this big swath of orange, Medicare. Another way to show it, just to get from bigger to smaller, employer coverage, Medicaid coverage, Medicare coverage. Then you have the uninsured, different numbers, slightly different from the previous, and then the individual markets. So whenever we talk about, the prices on the exchanges for the Affordable Care Act or the difficulties of the private insurance market, we're talking about this group, but we have these other groups that are undergoing their own experiences and their own changes, and they're larger. So this is the one part where I don't plan to speak, for a moment about people's coverage when they're poor, but people's coverage when they're working. And what you see in the employer market is essentially that if it's a large firm, the percentage of those companies, I think it's larger than 100 or more or 50 or more, the percentage of companies that offer insurance is typically high, and it's not really dropping. Maybe it dropped a little bit from 1999. And maybe here this 50 to 100 firm, just slight kind of downtick, but it's not radically lower than it was back in 2005. On the other hand, for small companies, and do any of you have family members who are running small businesses? Yeah, so that's where the insurance costs get to be really difficult. And the percentage of those companies that offer insurance is really dropping, and that's where the stress is hitting because of the way the insurance mark. And I think I wrote 50% here in a corner, like, wow, so only half, basically, of those small firms can offer insurance. The squeeze for them, I think, is pretty obvious. Employers have rising premium costs. They don't really have the power to bargain for a better deal because essentially the hospitals and the doctors, et cetera, are demanding a certain payment from the insurance companies, and the insurance companies have limited leverage to force the doctors to charge less, and they pass that on as much as they can to those small companies. In 2016, about a quarter of working age adults with workplace coverage were underinsured. And there's kind of criteria here. I don't think I'll test you on the specific criteria, by the way, but the notion is if you're spending a lot of money out of pocket one way or another to deal with covering to get health care, even when you're insured, the term is underinsured. Okay. I guess this is a multiple choice question. I didn't put it in with the electronic, so we can do show of hands here. What's typically true about lacking insurance? A, I'll just read these through quickly, and then we can have raised hands. People lacking health insurance and still get health care when they have to. The majority of people without insurance lack a primary care doctor. If you're uninsured, you're more likely to postpone or forego care when it's needed. None of the above, all of the above. I'm not even sure there's actually a true right answer to this. How many want to go with A? Still get care when they have to. How many want to go with B? Okay, so not a lot of people are convinced you lack a primary care doctor if you're uninsured. How many want to go with C? Postpone or forego. Okay, like 2 hands. 3 hands went up. How many want to go with D? None of the above. No hands. I saw a finger. E, all of the above. Okay, so people say all of the above. I think what we'll find out is that there are certain ways you can still get health care when you have to, but it's costly. I think what we're going to find out is that most people without insurance still actually identify someone as their primary care doctor. And that if you're uninsured, you are more likely to postpone or forego care when it's needed. So perhaps C is more right. Okay, I know bronies are out, but let's talk about a case. A 39-year-old analyst for a nonprofit museum, this is a real person, who makes $39,000 a year, this is probably 2009 or 10, has a lump in her neck. She has a visit, an ultrasound, and a biopsy done at a teaching hospital. She does not have insurance because her nonprofit museum does not insure her. She's diagnosed with thyroid cancer. She has not paid for the visit, the ultrasound, and the biopsy that she had to get the diagnosis. So the hospital has already initiated collections activity against her to try to recover the money for the visits she already had. Her endocrinologist, who has felt this thyroid cancer and said she needs to go to this surgical clinic, and the surgeons at that hospital say, look, you've got unpaid bills, we cannot see you. So imagine this is your friend. Your friend says, I don't know what to do, I'm afraid I have thyroid cancer. I just wanted to see if anybody's willing to make a few suggestions for this individual. What could they do? Where could they go? Let's assume they're in a major city. Any suggestions? Yes, in the green. Oh. So, yeah, so many major hospitals, particularly if they're nonprofit, have a fund of some kind or a commitment where they have an evaluation which you'll have to seek. It's one thing and so that would be possible, is to try to get into some sort of charity care program. Now, it may be that her income of $39,000 may be too high for that, but that would still be a reasonable thing to suggest to a friend like this. Yes? So clinical trial, I mean, it would be, a lot of lump removals may not have, clinical trials at all hospitals. And there would be an ethical question in my mind about the idea that those who are too poor must go to be research subjects. I think that could even raise concerns for the investigators as to if that's how they're finding their people. But in the real world, that wouldn't be impossible for somebody to start asking and looking. Other possibilities you might recommend? No one? Wait, is there a hand up that I'm missing? Yes, in the back. Good. What? Okay, go to Costa Rica, and because they might actually have a low-cost thyroid lump removal, you have to make some phone calls, get on the internet, talk to people. The idea of shopping around for a lower price carries pitfalls, like follow-up can be challenging. There might be less regulation on the care that you get, but it is not uncommon for elective surgeries, in particular knee replacement, a number of things like that, where people do go overseas, cataracts, and get a lower price for the same care. You have to stay in Costa Rica, obviously, for a while. Yes, on the left. Go what? I love it. Okay, so 7 years ago when I gave this talk with the same example, no one mentioned that. It's kind of like we're in an evolving time. Might need to GoFundMe to $100,000, which is tricky without a good publicity campaign. But if you can make the thing go viral, there's a chance. And last one. No. Oh yes. Okay. You. So take a hit in terms of future opportunities, but go ahead with bankruptcy, stop the collections, and see if she can get in. We talked about all of this. I asked the question, would this be a different story if it was an emergency? We didn't talk about emergency department use, but I think you all sensed that emergency departments don't do elective thyroid surgery. Safety net clinics, you may be aware that most safety net clinics like community health centers don't usually have thyroid surgeons on staff. Hospitals tend to restrict access to people who cannot pay, and they do it in very different ways. So that's just what I wanted to bring out. It is hard to get care when you don't have insurance. This is a nice study that was published this year looking at people who posed as uninsured patients seeking appointments for primary care, not for specialty care. And 80% got an appointment or were offered one if they could. They said, I don't have insurance. And the next question was, can you bring a full coverage, payment for the visit at the time of the visit? And if they said they could, 80% were offered an appointment. If they said not, then less than 1/7 of clinics offered an appointment to be seen. And it varied by state, as you can see. Community health centers, which are federally funded entities, although they also usually work as nonprofits, were more likely to offer an appointment to someone who couldn't pay. So it's a big deal. Yes, question? So in those community health centers, is there also the possibility that this individual would make too much money to be seen? Most community health centers might say you make too much money to be seen unless you're paying full freight. So the classic community health center might say, well, we have a $25 payment required or a scaled payment required that's scaled very favorably. But if you're above a certain income, you just have to pay $150 like you would at the doctor down the street. Emergency department doesn't apply for the thyroid nodule. And Tom, did EMTALA already pop up in earlier talks? No? Did the EMTALA Act? No. Okay, so this is good to know. So you can always go to an emergency room. You'll hear people say that, and it's true. By law, emergency departments are required to screen and stabilize for an emergency condition. The trick is obviously it won't work for the thyroid nodule, and the care is not free. They have to do something with the costs they've incurred in caring for you. So if they don't get money, the hospital will book it either as charity or as bad debt or as both. I have a statistic down there. You won't be tested on that. But the key thing to remember is, yes, you can always go to an emergency room for an emergency condition. It's just that it's not a free visit. This is a bit redundant. I'm not sure I'll harp on this. People who don't have insurance have a harder time with all the standard things you would expect them to have a harder time with. And it's often a lot better if you have Medicaid or insurance. But Medicaid sometimes still, people with Medicaid still have some barriers in terms of postponing care or cost issues or not being able to afford medications. Why are people uninsured? Ultimately, of course, it always comes down in one way or another to how do I pay the bill or get somebody else to pay the bill. It's a money thing. But losing Medicaid, suddenly changing your job, this is polling data, so that people just say it costs too much. That's not a surprise. But people describe the circumstances like, we divorced and then I lost my insurance. Or, 2% felt they had no need for the coverage. So people go through all these changes, and in that process, they become uninsured. So at this point, I sort of want to turn to Medicaid. And it's a picture of Lyndon Johnson with Harry Truman sitting next to him, handing him the pen to sign the Medicare and Medicaid Acts into law. Truman, of course, had tried also to expand health care, I think in 1948, and had led to the arrangement which involved the tax deductibility of health care benefits for employers. But prior to Medicaid, the basic thrust of the way we cared for the poor was sort of charity, almshouses. They were sort of ad hoc civil organizations, and many hospitals bear the history of religious and voluntary efforts to serve people, the poor, the aged, the insane, and interestingly, the disreputable. I find the word disreputable particularly interesting because it was taken as a given that someone will have to care for the people we don't like and we're not sure we approve of. But of course they're going to have to be cared for. That was sort of the inherent notion here. Contrast that, we're at an age right now where there's a big discussion about whether individual states should provide health insurance to people who are, quote, able-bodied but don't have a job. So at this point, there's a real push to say, we'd like to make sure you have insurance if you're engaged in reputable activities. But in the charitable framework, the disreputable were, perfectly appropriate for charitable support. Several major hospitals actually descend from these almshouses. But gradually from 1960 onward, there's been an effort to formalize how we pay for health care. Community health centers, the subsidies on the exchanges under the Affordable Care Act, and most importantly, Medicaid. And that's really what I've been thinking about a lot, is why is Medicaid, it was the biggest, after employers, it was the biggest color slice on that pie that I showed you earlier. As a percentage of state budgets, Medicaid is a tremendous, I think from a fiscal point of view, a tremendous drag. A lot of money this is all states combined, but for individual states it could be much higher. It eats up an increasing percentage of resources. And we sort of have to ask ourselves, why is it growing? What is making it grow this much? And I think to really understand the growth of Medicaid, you need to sit back and think historically. Remember what I said. Medicaid started in 1965. And if you follow this chain of logic, you will understand what's going on. This is a secret. Nobody else is going to tell you this. What else started in 1965? Anybody know? Dr. Dre. Dr. Dre was born in 1965. So what's Dr. Dre famous for? Yes, NWA. That's a key rap group, particularly from the 90s. And what's their most famous song? Straight Outta Compton. So if you want to understand the growth of Medicaid, you're going to need to delve into the lyrics of Straight Outta Compton. Okay, so, not that one. Okay. So when I'm in your neighborhood, you better duck. So right away, neighborhood. What do you think of when you hear the word neighborhood? Neighborhood. It's a neighborhood, but it's also the name of one of the most important Medicaid health plans in Massachusetts, a pioneer in the expansion of Medicaid. And duck. What do you think of when I say duck? Yes, a duck. Okay, so, but what state is famous for its ducks? Yes, Oregon, another state that's famous for massive expansion and experimental work with Medicaid. So right away, I think we have a pattern. You can see dot, dot, it's a pattern. But I've left out one part, and to make sense of this, you need to go back to NWA. Because what else is NWA famous for? Ice Cube, yes, exactly. And where do you get ice cubes from? Northern Canada. Northern Canada is very cold up there. That's where you get the ice cubes. So now you've got a real pattern here, a full triangle, and I think this problem explains itself. So now that we understand, and this will be on the test. Yeah, okay. So that's the growth of Medicaid. It's an Illuminati conspiracy. Okay, actually, so 1965 was that key era in which something happened. There was a three-layered cake of legislation passed, which really reflected three different views and perspectives on providing health care for people who didn't have it. Medicare Part A was like this hospital care plan, which everybody got just because they worked a job and paid their Medicare 3% off their paycheck or whatever. That's a little like a single-payer plan. It's a little like a European country almost. But then Medicare Part B, it's just this thing where you get doctor's visits. You have to opt into it. It's a little bit like an insurance plan. The patient has to pay a premium to the federal government in order to get their Medicare B benefit. That pays for the doctor's visits. So it looked a little more like insurance. And then the third part of this cake is a federal grant that would go to the states to help them provide care for the indigent elderly and certain other groups. And that's just a little bit more like sort of a charitable thing. a little bit like the old almshouses with federal money plowing in to help make them do well, but it's also kind of a subsidized insurance. So it's a different perspective on the care of mostly the poor. So it began as a federal patch to state indigent care programs. Federal government covers about 50 to 80% of the cost, depending on the state, sometimes a little less. The federal government mandates that you're eligible if you're a poor family receiving cash benefits. That's short term because TANF, formerly known as, I guess, welfare, is limited in time. Social security, supplemental security income recipients, misspelled, are people who are disabled or have become poor as a result, typically going into a nursing home. And the federal government essentially says, we'll give this cash and we'll provide the Medicaid. And then the states can say, you know, we want to cover more than poor kids, poor families, and aged disabled people. One of the key things to understand about Medicaid is the word entitlement. And I think usually I use the word entitlement in a kind of informal way to say it's a very entitled person. They just think they're owed things. But in the context of federal policy, an entitlement means if you fall into the category that the law defines as eligible, the government's expenses have to go to you, regardless of how big the budget is or how much money is available. So if there's more sick people, more old people, or new costly treatments, or an economic downturn, and more people need it, and they fall into the category of being eligible, the more money has to be spent. That's what defines an entitlement in the power and the policy world. Medicaid was expanded in the 1980s to make sure that pregnant women and children at under 133% of federal poverty level got it, but many states reached up to grab a greater percentage of pregnant women, and it was expanded to assure that there was coverage of all children with families at less than 100% of federal poverty. What does it typically cover? Well, some things are required by the states and some things are not. So a state must cover these things. Look at nursing homes, that's going to be a big issue, hospitals, physician. They can offer prescribed drugs. They can offer care of addiction. They can offer dental. There's a longer list. I just wanted to give you a few examples so you understand the design is always state-based. Then, you guys all knew about it, CHIP. 1997, in the wake of the failure of the Clinton care efforts, there was an effort to get kids who are above federal poverty level, and this can be done in different ways, as an expansion of Medicaid or a separate program, and the percentage of poverty that you have to be at for your family kind of varies from states. But this, of course, led to a big drop in the percentage of children who are uninsured, and it's federal money that the states kind of set up their programs in their own way. Just to emphasize, nursing homes, if it's a long-term stay and the person isn't independently wealthy, Medicaid is going to wind up being the payer, and it pays for 6 out of 10 nursing home residents. Obviously, if the individual is a former executive tier individual with a long-term care plan or $3 million stacked up, they can go to all kinds of things without going onto Medicaid. Roughly half the childbirths in America are financed by Medicaid. The dark blue signals the states where over 54% of childbirths are financed by Medicaid. So many mothers giving birth are poor, and when they are in that situation, those childbirths are paid for through the Medicaid program. Obviously, this was expanded. Now you have Obama and a small kid who's actually grown up since that picture. And it's worth understanding the nature of the expansion of Medicaid under the Affordable Care Act. This will get plenty of treatment in another lecture. But essentially, the rules were up to 138% of poverty. Federal government wanted the states to sort of say Medicaid's available, because who was left out? You'll see this. Who was left out in the old Medicaid arrangement were poor single adults. Your poor employee or poor non-worker, homeless people like I take care of. They just typically weren't insured in the old Medicaid form. The federal government offered to pay for this expansion at 100% of cost to the states, but then reducing it to 90%. They wanted it to be very attractive. They wanted to force every state to do it, and it's actually an option that the states were allowed to reject due to a Supreme Court decision in 2012. And you see 33 plus 18, does that add up to 50? No, that's because they always include District of Columbia when they describe these decisions. So anyway, states expanding Medicaid to date, 33, 18 decided not to take the option of expansion. You'll see that there's a slice across the southeast, and then this chunk that goes kind of up the middle. That was like a football move. And in a funny way, I mean, this is just speculative, but I always think of this as a political issue, being a former California to Massachusetts liberal, that the values that I think should lead states to adopt these expansions are not taken up by southeastern states like Alabama. And maybe there's truth to that, but another way to think about it is to say, what are the pressures on the states that have typically not taken up the Medicaid expansion? And this graph here is actually the tax revenue return to normal after the 2008 recession. And there's a lot of, not 100%, but there's quite a bit of correlation between your tax revenues continuing to remain lower than they were before 2008 and your decision to not take the Medicaid expansion. Essentially, maybe it's a political decision to not tax yourself very much, but then you finally sit down at the legislature, you say, okay, so we got to pay for 10% of the expansion, but where's the money going to come from? We're still making less money in our tax coffers now than we were before. So money is probably intimate to these decisions about the Medicaid expansion. The result is variable by state, but there's always a kind of gap for those states that have not expanded Medicaid. There's people who are in Medicaid in each state. Here you see parents in a family of 3. This is some sort of average number. Every state is different. There's people who are offered subsidies to get insurance on exchanges, and then there's a group kind of in between if they're not insured or they're in a bind, and it's often called the coverage gap, but it's different for every state. The picture of New York is not quite as bright as I wanted it to be, but just to give you a sense, here's Alabama. So who's covered under state programs here? Children up to 141% of poverty. By contrast, in New York, they chose higher thresholds for kids. They have CHIP. We have CHIP up to 312% of the poverty level. That's pretty good. New York went a little higher. Pregnant women up to 141% of poverty. It's higher in New York. The parent of a child can get Medicaid if they make less than 13% of the federal poverty level. That's like a legislative minimum. So if you're a parent, there's always been this distinction in the law about parents as opposed to single adults. I'm not sure why, but you'd have to make less than like $260 a month in order to then be eligible for Medicaid. There are some people who achieve that, but it's very rare. New York, even before the expansion under the Affordable Care Act, had things like this where single adults and parents were covered. We didn't take an expansion population. New York did expand Medicaid, and then it added yet another plan which was available under the Affordable Care Act to grab up yet more people, called an essential plan. It's technically not part of Medicaid, but only 2 states did these essential plans, Minnesota and New York. So states make choices with the money they have. We are near the end, and let's see what we are for time. We're good. We're good. I want to kind of give you a little bit of a sense of the arguments about whether healthcare coverage improves health. How many people think it does? I saw one hand. 2, 3, 4. Okay, a tidal wave. How many think it doesn't? Okay, 2. How many are just a little too tired to vote right now? Okay, I saw more hands right there. Okay, it's all right. Don't feel bad. Okay, so it's very hard to answer the question whether healthcare coverage improves health. Remember what I said even about access. Access isn't just about offering people a way to pay for something, and health is not just about whether you get to a doctor's office. But certainly one of the most interesting efforts to look at the question was a situation where Oregon was in a position to expand Medicaid to a limited number of people, and they randomly assigned sending people a letter saying, hey, you're in the group who could apply now and be eligible if you just go through the paperwork to get this Medicaid. You're randomly assigned. And they just didn't have enough to give out to everyone, so they did it randomly. And then they asked people if they would be willing to be evaluated before, during, and after to see, how things played out for them in terms of health and financial well-being. It's very rare that you see randomized controlled trials in an area like health policy. So they had to be relatively poor with poor assets. The main analyses were restricted to the people in the Portland area, and Medicaid was offered to 10,450, not offered to 10,340. This doesn't mean they all got it. They had to sign up for it, so it's a percentage of each group that got it, about 2/3. The average duration of Medicaid for the people who got it was 18 months because you had to kind of renew it every 6 months. And statistical models were set up to identify the trend effects of getting Medicaid. So one of the things that came out quickly, well, not quickly actually, the first results were more people who get insurance spend less money. They liked that. And then there was a big report in New England Journal of Medicine that said, look, the Medicaid offered group did not have better glucose control in the diabetics and did not have better blood pressure control among people with hypertension, and cholesterol levels were not lower in the people who got Medicaid. So that looked like a pretty negative finding, and Vic Roy, who is a person, one of the, I think I put it as an optional reading, laid out an argument that Medicaid doesn't improve health. He didn't actually argue that health insurance doesn't improve health, but he said, look, Medicaid clearly doesn't. Of course, there's arguments about this. I just want you to understand there's one. Here are 3 disease conditions or arguably pre-disease conditions where there's no improvement in the trial. Oh, and the biggest argument you often hear is if we get them all insurance, they won't go to the emergency department. But I think we're looking here at the percent of the population with ED visits and the number of emergency department visits per person. And actually, when people got insurance, they went to the emergency department more because they were insured. So didn't avert emergency department visits. And there's not even a hint that the effect goes down over time. Like, it's stayed up for the full duration of follow-up. So, mixed findings. Medicaid boosted service use. It boosted spending. The people in the Medicaid offered trial arm did have lower financial stress related to medical care. They had more likelihood of reporting a usual source of care. They did have greater likelihood of actually getting a treatment for diabetes or for depression if they had those conditions. They did have lower depression scores on average. Whether that's, I think those scores are not restricted to the people with depression, so it's sort of like everybody gets asked a set of questions and they seem to be less blue, basically. And they gave themselves better ratings on a general self-reported health scale, which we can argue about whether that self-rating is a powerful indicator of your overall health. It certainly predicts death, but it's a subjective question. I'll give a little bit of a defense of the study and suggest why maybe the lack of findings on certain health conditions need not be seen as a terrible defeat for the argument that health insurance helps with health. One of the things to bear in mind is this study was based on a group of people who were offered Medicaid and then enrolled. And there were people who were not offered Medicaid who managed to get into it because of a change in life circumstances. And there were lots of people offered Medicaid who didn't ever bother to do the paperwork. So we're looking at the effect of being offered something, and being offered Medicaid made you 24% more likely than non-offered people to actually wind up on it. So it's kind of a modest intervention. The result of that is that you have relatively small numbers of people with those conditions like hypertension and diabetes to assess the outcomes in. There were 280 people with hypertension who got Medicaid, versus 280 who did not. There were 110 with diabetes who got Medicaid versus those who did not. So if you're doing a trial of a medication to treat hypertension or diabetes, and I said, I'm Pfizer, I want to do a trial of a new hypertension drug, I'm going to do it with 280 people, and say, no, that's the wrong number, you need to do 5,000. It's just, in order to detect the kind of small effects that emerge as a result of getting a treatment, you wouldn't do it with that small a group. So we talk about this as a matter of a lack of statistical power. There are non-randomized studies which hint possibly at mortality benefits from expanding insurance by comparing states. In the readings for today's talk, there are really 3, one of which is an argument that there is a benefit from health insurance. One of the authors of that argument that there is a benefit is the first author of the Oregon Medicaid trial. But needless to say, I think you need to step back and realize insurance clearly is not the main plank of generating health. It's the main plank of our taking care of ourselves or taking care of each other, or assuring that certain bad things can be handled. But insurance influences access to care. Access to care to some degree may influence health, but that association is influenced by tons of other things, including where you live, who supports you, whether you're alone or with others, whether you're in a house or not. So, I think I put this as a discussion point. Let me respect time. Oh, we're okay with time-wise. It's 9:11. But so what if insurance was this, offered this? It reduced financial risk. That's credible. It moderately improved access to care. That sounds plausible. There's a modest outcome benefit for some diseases among a small percentage of people who have them, maybe, and no impact on the overall health of your population. I mean, what if that's what insurance achieves? And, would it still be a compelling social goal to pursue that? And is it a compelling social goal to pursue at the expense of other things? Maybe you have to spend less on schools in order to advance this goal. Is that? My hope is to transmit to you a sense of uncertainty and ethical, moral discomfort. Are you getting it? Okay, that's the goal. I mean, I'm a person who would, by inclination, want to make sure every child, every person, everything is insured. But what we promise that delivers may be less than what we aspire to hope it delivers. I want to ask Tom if you want to comment on this at all.
I feel like you're fighting the wrong battle. I feel like for everything the students have already been told, they know that healthcare is going to have a limited effect on health. So it seems to me that the argument for covering the uninsured and expanding Medicaid has to be a different argument. So many other things influence health, but that's not the point. I mean, the point is we want people to be taken care of when they're sick. We want them to be able to go to the doctor and get help. And that's what giving people access can do. The fact that it doesn't have any particular large effect on population health is neither unexpected nor an argument against doing it.
Okay. That's good. Thank you for the color commentary. It's very helpful, actually. Do you guys have any, I don't know if there's any other, yeah, there's no other slide. Any other thoughts from you on how you react to this? Because we have a few minutes. Yeah, go ahead. What would, let's define the term diverting Medicare dollars to improve access to care. What are you thinking? Pay the Medicare providers less and get everyone a bus? So I'll answer the question in the way that aligns with my political and emotional biases. If I could reduce the rate of payment to highly paid specialists and redirect some of those dollars to making sure we have strong reward structures to get primary care providers, doctors, or nurse practitioners into every county in Alabama, I would favor that. In different ways, sometimes that happens, but that's just purely my emotional reaction. It's not worth more than that. Other thoughts or reactions?
I'm wondering if the timeline of the study was too short, and maybe the benefits of having insurance start from birth, like preventative care.
Yeah.
So then an 18-month
Window.
having access to care, your behaviors are already established. What are your thoughts?
So a lot of people who, so I think that that's a credible speculation, basically. If you look at my child who's been going to doctors since he was born, of course it's in the context of a very health conscious and supportive family. It may be that he's positioned to maximize his benefit out of all health care in a way that might not be the case in somebody who's been uninsured and or just poor and dealing with a lot of difficult situations, and then suddenly has maybe 18 months of access to care. That's a hope. It's, of course, a hope is not the same as evidence, but one could make the case that there might be stronger benefits. Obviously, Dr. Baker, B-A-I-C-K-E-R, she thinks that over time such benefits would accrue, and that's part of the point she tries to make with, I think, Atul Gawande in the article, the reading for today. Yes, I think I saw a hand behind you. Same thought. Yeah, the Oregon trial is what it is. Like, it's Portland. I mean, Portland itself is just kind of an odd thing. And it's, and it's time limited. When you want to go to scale, you end up with non-randomized data. We compare states that expanded Medicaid to states that didn't expand Medicaid, and there's hints of benefit, and yet you get it's analyzing at the state level, and there are loads of challenges with the value and the reliability of statistical models that treat each state as a unit of analysis as opposed to a human being as a unit of analysis, what you control for, how you assume a policy takes effect. Most social policies don't land on the state at a moment in time, have immediate effect that is constant, that never goes down and never goes up. And yet almost all statistical models that compare states assume that. So that it's tricky to use those state comparison data. I have used them in debates with Tom, but they have flaws. Other reactions? Yes.
So we've seen some studies that have examined the effect of putting societal money into the healthcare system and that's impact on health. Are there any studies we can look at that examine the effects of putting money into other systems that we know?
Social determinant.
Yeah. Does that make sense? Like,
Yeah.
effects of putting more money into education on health, putting more money into HUD on health.
So the key question, if you throw money into housing, will it improve the health of the people who receive the housing? If you throw money into creating walking paths and parks, will it improve the health of the community? These things are things that that I see communities doing all across Alabama, honestly. I mean, we went to Walker County last year, and there's groups of people coordinating, creating playing fields and walking paths and all these things. I don't think I can give you a definitive answer. I will underscore it's hard to study. It's a natural experiment. You rarely randomize communities to have those kinds of impacts. So I haven't seen anything. Tom, have you? Proof that investment in social determinants of health improves health outcomes. And we'll ask Andrea too. She might know. She's shaking her head with a frowny face.
Well, I think it's
Mixed.
For example, one of the things I think people talk a lot about are
Food
food deserts.
deserts.
Food gardens or food deserts, that's going to improve the health. And I think it's, similar limitations in those kinds of situations that we have here in this Oregon experiment where time limited, it's 6 months. Are you really going to have a thing in fact stay on diabetes list? Because now you have fresh vegetables for a community garden for 6 months. It's just hard to capture the benefit of that in a short period of time.
So just in case people didn't hear all of that, hard to capture the benefit. These interventions tend to be short-lived. They tend to be one small part of the puzzle. You create a a community garden, walking path, and when communities do these things, usually they do it as a matter of shared commitment, an ethical sense that this would be a good idea. The argument is made, it'll improve the health of our community. Proving that over time is hard, but entities like Robert Wood Johnson Foundation have trackers that actually track the degree to which each county in America has tried to